sessions. And for this talk, we are going to be hearing from Mr. Steve Reames. You've all met him in some capacity or other this conference because he's been running tech support for us, which is super awesome. But when he's not doing that, he's also the executive director of the Ada County Medical Society, has a lot of experience doing nonprofit work, and also in the areas of burnout, self-care, suicide prevention. And so this is going to be a fantastic talk from him. I just want to also mention that we do have a break after this coming up. I know it's been a pretty busy first half of the day. And hopefully you can all have a chance to visit the exhibitor hall during that break, because there will be a raffle at the end of the day during right at the end of our last session. So remember to check in, and with that, it's all yours, Steve.
All right, thank you very much, and glad to have everybody. We'll try to keep everybody awake with their post-lunch little snooze probably feeling, as we all feel that kicking in. I want to talk about this picture, which I chose very much on purpose. I think that it tells the whole story of what I really want to talk about. The House of Medicine has experienced a disaster over the past 15 months as it's responded to the pandemic, and really over the past 15 years as you look at the amount of physician distress in the system. So our goal today as we talk is really, how do we elevate this House of Medicine so that the floodwaters that eventually always come at different points and become so rampant, they're going to continue to come. How do we elevate the House of Medicine so that that doesn't strip away the things that medicine is built on as a foundation? So I have no financial disclosures, and also I'm not a doctor, but I have played one on TV. Actually walking through a news shot with Dr. Carl Watt's lab coat on. So you are free to take or leave anything I have to say, since I'm an outsider to the profession. Also, the other disclosure I have is that once we started talking about burnout more often, suddenly burnout became much more prevalent in Idaho. I'm not really sure why, at least according to Medscape in 2018. So way to go, Idaho. You can take or leave anything I say. It may not be effective. Before we start, however, I do want to ask you this question. How are you doing? And I want to do this by way of this poll. And just tell me right now, before we get started, are you at the place where you just love your work? You have no signs of running out of steam. Occasionally you're feeling stressed, definitely getting tired. Go ahead and start voting in there. Some of you may be just like, I'm flat out exhausted. I can't take it anymore. I'm at the point where I need changes, or I may need to seek some help. So let's just find out where you're all at, because I think it's really important for us to recognize as we talk about this content. Some of these are things that are going to change that we need to do right now, but some of these are big, long-term things that take some energy to get to, and not everybody is going to be able to lean in there. So with about 60% of you guys voting, a few more coming in here, I can tell you that most of you are feeling, just occasionally feeling stressed. I'll show it here with 65%, occasionally feeling stressed, and then just kind of spread out. So that's good. What I see in that simply is this, is that we have, did I share those yet? You can see those. We have an audience here today that has taken pretty good care of itself, that has balanced its work life, and that is doing a good job in terms of doing the things that bring you joy in medicine. And that speaks well to why you're here at IAFP every year. Now, what it may concern me is the people who aren't in this meeting, who just don't have time, energy, or can't get up out of bed to do something like this, where you really do get to connect with one another and enjoy learning together. So what are we going to address today? We're not going to talk about any one particular thing. We're talking about physician distress in general, which encompasses a whole bunch of terms, right? Burnout, moral injury, vicarious trauma. And we want to address the whole of physician well-being, whatever term you would prefer to use, like the joy of medicine or physician vitality or engagement, whatever. Now, if we listen to someone like Adam Grant, you know, an organizational psychologist, best-selling author, fixing burnout. I mean, what's the problem? He said at the beginning of the pandemic last year, he said, hey, just place fewer demands on people, give them more control over how to handle those demands, and provide support to handle them. Boom, you know, it's done. And we know that it's not that easy. And in fact, if I were to ask you, well, what is the answer to burnout or physician distress? We already know the answers are: doctors want to practice good medicine and take high quality care of their patients by deciding what that is in terms of pace and treatment options without a bunch of hurdles to jump over, and provide it, and to be paid a fair wage for doing it, right? This isn't difficult. And so the question is, why don't we get no respect? Why don't we get the answers that we need are right there? Why can't we do that? And we know that the issue of physician distress is something that is wide ranging. And as I shared before, as Ada County Medical Society began working on this in 2015, and because I'm a comm major by training, I always think of ways of trying to explain complex things in pictures, metaphors, stories. So in 2017, I began to develop this story of Burnout River. Why do doctors keep going over the falls? And eventually it became a talk where I would talk about the different places of intervention, because this is a multifactorial complex issue, right? And there were people who were on the safety net side, there were people who were on the upstream side, there were people who were talking about we need to teach better resilience, better survival skills when people fall in the river, we need to deal with physician suicide. And my whole point of doing that talk that way was to say, this is a big ecology. Physician distress is a big ecology, and there's no one thing that needs to be done. And as soon as I finished kind of constructing this, somebody with actually much better training than me and much better ability, Dr. Colin West at the Mayo Clinic, he and several others as part of the CHARM initiative developed the Charter on Physician Wellbeing. And it's a very structured way of looking at these multifactorial places along this river, along this ecosystem, where interventions for burnout and other things could happen. And so I want to point this out to you, because later on in my presentation, I'm going to come back to this structure and talk about a few examples of some things that I see here in Boise and in Idaho that are going well, that get specifically at that. But first, let's talk about that river. You know, it used to be in medicine that you would, have different seasons where you would shoot the rapids, you would be paddling as fast as you could, hanging on for dear life, right? And then you would get to a break where you could say, I can rest now. You would get to some flat river, you could coast for a little bit, and you could take a breath and recover before that next season that was very difficult. And unfortunately, we've really entered over the past 15 years a season in physician practice where everything is VUCA, volatile, uncertain, complex, and ambiguous. That's a military term. And it's just like one big set of rapids. You got the river on this one side that's like no big deal, and then you've got it at flood stage. And unfortunately, when we think about flood stage, we have to think about this past 15 months. COVID has been a flood of biblical proportions in healthcare, because what was once functional is now completely dysfunctional and impassable. A channel that used to be safe with the same amount of water in certain channels is dangerous, right? So the pace of change in the industry that is constant. It wasn't that the channel was unsafe, it's that there's so much water in that channel changing things. And so you have once what was safe for doctors and other workers to be in becomes completely inundated and unsafe to be in, both physically and mentally. And then as we think about going back, and those were pictures from the Sendai, Japan flood, there are going to be places of medicine that may become completely unlivable, and we shouldn't rebuild them again. And amidst the pandemic, I find it very interesting that everybody was very much encouraged to ask for help. How you doing? Take care of yourself. The healthcare heroes, everyone's, cheerleading and doing all the things, the signs, the honks, the horns, the free meals, and all those things. Take care of yourself, doctors, take care of yourselves. And I keep on asking myself, if it's good enough for a pandemic, why isn't it good enough for all times? And so I really believe that we're at a moment in time where this is an opportune moment to seize and advance physician well-being. And you see all these different headlines, all these different journal articles and editorials and opinions that say this is that moment in medicine. This is the time to advance physician well-being, to change the culture of medicine towards wellness, to renew the profession. So what we want to do today is simply this. We want to stop and take a breath. In fact, Steve, slow down. I can't sustain a pace like that, and neither can you. We cannot sustain a pace where we are running hard all of the time. We simply can't. Our bodies won't let it do us. Our hearts won't let us do us. Our families won't let us do that. And so I have taken the liberty of cutting a whole bunch of slides from this presentation so I don't have to talk fast like that I did for the first 10 minutes. So those are in the notes and you can find those there. But first, let's talk about the Stocktail Paradox, because this is a moment for us to stop, breathe, and look around. Now, if you don't know who Vice Admiral James Bond Stockdale is, first, he has an awesome name, right? And this guy was born in 1923, well before Ian Fleming's books came out. So James Bond Stockdale. Plus, we know if a movie comes out about him, who's going to play him? Hugh Bonneville of Downton Abbey fame, right? Shoe in for the role. No, so Admiral James Stockdale, he was the highest ranking officer in Vietnam in the Hanoi Hilton POW camps. And he was tortured randomly over 8 years imprisonment, no release date, no prisoner rights, no guarantee of survival. And the best-selling author Jim Collins asked him one time, he said, who didn't make it? Who didn't make it through the POW camps? And this is what Stockdale said. He said, oh, that's easy. It's the optimists. It's the people who thought, oh, we're going to be out by Christmas. Christmas would come and go. Oh, we're going to be out by Easter. Easter would come and go. We're going to be out by Thanksgiving. And then Christmas came again. They died of a broken heart, he said. And so the Stocktail Paradox, which Jim Collins coined, is this idea that you have to be unceasingly optimistic about the future while brutally honest about the facts. And what he illustrates is that he was not going to have regret at the end of this. He said, I will turn the experience into the defining event of my life, which in retrospect, I would not trade. He was forecasting himself, looking backwards. And so this is really important for us to do right now. And so if you think about this moment in time, we've been bumping along, burnout and all these things, then boom, COVID hits. And it becomes this moment in time that we have an opportunity to change trajectory as we see kind of the light at the end of the tunnel. And we're going to change it off of the baseline here. If you projected yourself in the future, like James Stockdale did, and you look backwards in time now, the question would be, what did you stop doing? What did we stop doing? And what did we or you start doing, right? Or as Dr. Gunther put it yesterday very well, what would liberate you to love your work? We have to maintain the tension of the brutal honesty of the facts with relentless optimism. So let's take a look at the practice of medicine before COVID. What affected physician well-being before COVID? Well, let's talk about medical training culture, for example. It become workaholic lone rangers, perfectionistic superheroes who have difficulty with emotions. That's what's produced by the medical training culture. And I know some of you might be saying, I would love to be any of those people. They're all my heroes, right? And some of you ladies are going, where are the women here, right? And I'll just say, because those are iconographic images, no gender bias here. We all know the stats that say medical students enter into training emotionally healthier than their peers, and they often leave damaged individuals emotionally. So that's a problem. Never show weakness. Patient comes first at all costs. And some of that is purposeful enculturation, and some of that is a byproduct, right? What about the healthcare industry culture, right? Death by 1,000 paper cuts, EHRs built for billing and collection purposes, the constant pressure being told to do more with less, malpractice concerns, defensive medicine, the industrialization of medicine, so that it becomes less of primarily a physician-patient relationship to one where the patient is interacting with a team of physicians. How about workplace culture? Isolation because of technology, chaotic clinic environments, the C-suite disengagement, the gerbil wheel that Dr. Epperly mentioned today, personal boundaries that aren't respected or really don't stand a chance in the face of an onslaught of the realities of the practice of medicine. And we know part of this, as again, Dr. Epperly mentioned, part of this was produced by the triple aim, the goal of population health, per capita costs being lowered, and the experience of care going up. And those are fantastic goals. And unfortunately, over the past 10 years, what's happened is that has been built on the back of physicians to carry all of that labor and all of that burden as we're taking apart pyramids from one structure, right, and reassembling them into the things that we talked about this morning. And so whenever I think about Pharaoh and in Egypt, I think about him telling Moses, you just need to learn how to do more with less, because that's what we do in healthcare, right? We're just gonna have to learn how to do more with less. Keep making bricks, we're not gonna give you straw anymore. And hence emerged the quadruple aim in the annals of family medicine. The care of patient requires care of the provider. And then of course, there's just the rest of life, which all of us have, right? Marriage, families, car repairs, student debt, aging parents, all of those types of things. And all of that was prior to COVID. And then boom, it hits like a tidal wave. And it leaves physicians feeling like they are the ones that are carrying the burden of this care. And we know it's not just physicians. If we're honest, we know it was also the nurses and the administrators, and they also carried a lot of weight too, and that there was distress throughout the whole system. And so what I want to do right now is I want to launch a poll and ask you guys some questions about how you are doing. Let's end that one and let's do this one. Which of these factors in your workplace significantly and negatively affected your well-being over the past year? Answers are anonymous, so just feel free to go in there and you can click on any of those that you see there. Which of these factors in your workplace significantly and negatively affected your well-being? I'm not seeing anybody vote. Is nobody able to see that, James?
I'm a co-host, so I just see the results like you.
Well, I'm not seeing anybody vote, so I'm just going to end that polling. And I'm just going to ask these things. How did rapid telehealth implementation go? Or shifting patients to alternate sites, treating from behind a mask all the time, clinic practice closures, financial impact, furlough financial impacts on you, salary reduction financial impacts on you? What about quarantines and furloughs creating staffing challenges, or your own quarantine or catching COVID? You had anxiety for your own health and safety, anxiety about your family's health and safety. Is that working again now? But the submit button didn't work. I suppose you have to go all the way down to the bottom to get the submit button. In any case, you see the poll questions. You can see all the things that could have affected you. It's probably not worth taking the poll, but I know all of these things affected all of you, both at work and at home. And maybe it's worth even putting in the chat the one that you felt was the most. That's fine. I'm going to go ahead and end that since that didn't quite work the way we wanted it to, probably too many questions, and just talk about this because Dr. Serio mentioned this, the long tail of mental health impacts. This was a tweet put out by a doctor last March, and he shows here the health impact of the pandemic. It was very quickly, of course, the immediate mortality and morbidity of COVID-19 with a second wave impact of resource restriction on non-COVID conditions that were urgent. And then the tail of the third wave, impact of interrupted chronic care conditions. And then the fourth wave. And that was an immediate rise and a sustained wave that we're going to continue to see both among physicians and others, psychic trauma, mental illness, economic injury, and burnout. And so this is going to be ongoing for some time. And in fact, I believe it's probably at this point, if we think about this, and I'll give Dyke Drummond, the happymd.com, credit for pointing this slide out. This is when we begin to actually stop and breathe and take a look around. And if we were in a movie, this would be when the person would rush over and go, oh, let's check that where your head is bleeding. And you go, my head is bleeding. I didn't know my head was bleeding, right? And this is a time for us to find out where ourselves are in terms of our emotional health, our physical health, and other things like that. And the phases of psychological reactions to disasters, because it's been a long spread out train wreck, and we're just finally maybe getting close to the end, maybe, right? Reconstruction is going to take a while. And so I see some of you have put some answers in there, the information, infodemic, Mike Fouts, at work, the mask, at home, the kids, right? All of these things were difficult for people to deal with. So returning now to the charter on physician well-being, because this is really where we want to focus our time. Societal commitments, organizational commitments, interpersonal and individual commitments. So let's break this down. Societal commitments, and there's two underneath this they described. One was foster a trustworthy and supportive culture in medicine. And to me, that would span everything from patient expectations to the healthcare industry to medical education, the government payer reimbursement. It's the whole kit and caboodle. That's the big channel that medicine is flowing in, right? And changing that isn't something a single individual doctor or even workplace or health system can do. It's going to be something that's going to take more than that. And then advocating for policies, top to bottom, that enhance physician well-being. Well, in the charter, they give an example and they state what they mean by this. They say alignment between the stated values of medicine and actual practice is essential for enhancing engagement in work and trust in the profession. Individual physicians and physician leaders have a responsibility to examine the extent to which the culture of medicine, broadly and locally, facilitates meaning, fulfillment, practice, and professionalism. And it's a whole long paragraph, which you can get to. But how do you even begin to approach something like that? How do you begin to compare the stated values of medicine to actual practice? Well, fortunately, Tate Shanafeld and others from Mayo Clinic Proceeding published this in 2019. And they gave this chart as an example on healing the professional culture of medicine. And so they say, okay, let's take a domain, the culture of our organizations and healthcare system. We say that physicians are professionals and we trust them. Our behavior is prior authorization, excessive documentation that justifies billing, prevent malpractice suits, right? Defensive medicine. What does this reveal? We sort of trust you. Professional culture. Self-care is important. Artifact, excessive hours, work always comes first. Don't take care of ourselves. Don't even do all the annual physicals that we recommend our patients do. What does this reveal? Self-care is not really that important. Short-term productivity is the most important thing rather than long-term sustainability. As an example, I'll give an employer I know here that it buys back physician vacation hours if they don't want to use them, because they want the physician's productivity more than they want that physician to be recharged and rested for work. That's a misnomer. That's talking out of two sides of your mouth. So let me give you an example of something that I think is happening here in Idaho that you may not be aware of. And it's the Idaho Physician Wellbeing Action Collaborative. Dr. Deb Roman, Dr. Ed McEachran, who is with Pacific Source, they initiated this a few years ago. And I'm going to play this video from Dr. Roman, who explains how they have attacked prior authorization reform. And even though IMA and others have been doing this for a while, they're actually getting some traction, and she'll describe what that looks like.
So we pulled together physicians, people from our hospital systems, payers, representatives from the payers, the payer industry, people from the Idaho Independent Doctors, the Insurance Commission, and different people to see what we could do about a particular project. And we wanted to pick something that was actionable and something with high impact. And we picked prior authorization. And we started with trying to simplify the process. How do we get the information from the payers to the physicians in the EHR at time of service? And make it possible for a physician to look at the formulary from that payer and say, do I need prior authorization? If they do, apply for it then. Get their answer back and send the patient off with a script, knowing they could get that medicine as soon as possible. And what we found is that the technology for that exists, but in small pockets throughout the country. And so we wanted to see how would we bring that to Boise and to Idaho in general and enable the physicians there to have that technology. We also found that there is the technology available to get costs and alternatives, and sometimes cash prices as well as coupons, so that for certain patients, when these medications were too expensive, we could deal with that at time of service. And finally, we found that we were looking at the system in general. Is prior authorization the most effective way to handle quality care assessment? And what was so interesting is that we all agreed that it wasn't. And here we thought that the payers thought that it was, the doctors, the payers had ideas about the doctors, and we all came together and said, this doesn't make sense. So how can we change it?
All right, so that's a great example, I think, of how they started with this goal of physician well-being. What can we attack? Really specific. Where on the river are we going to position ourselves? And let's go at it. And 3 years later, they're making some traction. And so that's a good example of that societal level. What are the policies we can do to enhance physician well-being? And you can view a 15-minute form where she goes into a lot more detail on our website, on the YouTube website, actually, ACMS Idaho. All right, so another thing that I've noticed is if you look at the beginning of April last year, all the way through this year, you see a whole bunch of editorials and op-eds in journals and public publications about this idea of stop calling healthcare workers and physicians heroes. And the issue there is the feeling is that if we just tell you how heroic you are, are willing to put your butt on the line for everybody, whether it's a lack of PPE supplies or time to recover, and you're our hero. Hoorah, good job, keep doing that. And people are saying, no, we're not going to keep picking up the slack. We're not going to keep rescuing, which we do really good as an American culture, don't we? Right? If you've watched enough Avengers movies, you know that this American hero myth is really a part of our cultural underpinnings, right? The person who's supernaturally or chemically unable to confront evil, to be invincible, they need to be everywhere at all times. But even before then, it was the Lone Ranger, it was whoever it was, right? And doctors by training are led to believe that they can and should fill this role for patients. And that fits with that very American model of rescuing the individual at all costs, whether it's healthcare or hostages, right? And so we should be paying attention. This is a moment in time for us to say, how do we begin to talk about physicians? Yes, we want to honor those who have been selfless. We want to cherish those who put the needs of others first. But how do we do that in a way maybe that is more balanced, that also honors those that put sustainability in a lifetime of service by preserving themselves too? And so thinking about that, that's a good opportunity for us to think about those societal commitments and the cultural things that we celebrate, right? Because culture is formed by the things that we reward and the things that we punished as part of it, as well as the language that we use. All right, at an organizational level, once again, thinking, what did I stop doing? What did I start doing in 2021? Building supportive systems, developing engaged leadership, optimizing highly functioning interprofessional teams. And you might even right now be thinking, as you jot down some ideas about what this might look like in your organization. The paragraph example, optimal systems support for well-being, includes providing adequate practice resources to manage the pace and volume of work, and designing spaces that streamline work and communication, et cetera. And it goes on to say that. Now, we have here Dr. Fouts, the hassle. He's got a great solution for us. We'll play a video. His hassle of playing Tetris with 15, 30, 45, 120-minute appointments every day, especially during the pandemic, they came up with a fixed appointment time box solution throughout the day. Here's his explanation.
So we settled on a 30-minute visit for everybody for whatever they were coming in for. And we did it for both, all three of the providers. At the time, that seemed okay because we didn't have higher volumes than that. Since then, we've tailored it to 25 minutes for the two MDs, and we still use 30 minutes for our PA, who's kind of still building her practice. But in doing that, it showed me that it was easier to be present with the patient because I wasn't so worried about, okay, how long is this again? And what am I supposed to finish with them? I could really just say, well, the most I would ever spend with a patient is 25 minutes. So just use the time productively for what the patient needed and meet their needs. It really allowed me to be present in the exam room, focus on them, take care of everything they needed instead of leaving some things undone until later when or if I got to it. And that helped to be more efficient in the way I cared for the patient. I was also able to, with the leftover time on the visits that I didn't have to use the entire visit duration for, to work on administrative items and get things done in a more timely fashion so that the employees, my team members, could help move that back to the patients. It also allowed me to use our rooms a little bit better. We could designate a room for each visit rather than just seeing, well, what's open now, and schedule the patient at their visit for that room. At the same time, we opened up online scheduling, and this allowed a very open access schedule where the patient could schedule with their doctor anytime they were available for whatever they were coming in for. And we didn't have to double check and verify every visit that was put in. In most cases, can close the visit in the exam room before I leave to see the next patient. And some of that is because I am present. I am just thinking about this instead of three other things and worrying about, well, there's an urgent issue coming up here I need to deal with. I have time at the end of the visit to check and see, well, what is urgent, and deal with it right then. In addition, the patients themselves sometimes bring up other issues, and I feel like I have a better idea of whether I can address that then. Sometimes it's no, but a lot of times it's, well, yeah, I know I have this going on, so let's take 5 minutes and take care of that now. or we're really close to being out of time, I need to get to my next patient. I have a better feel for what that duration looks like. When you change from 15 to 30 to 45, you get lost in terms of where you are in the visit, the timing of it, and the flow gets muddled sometimes. So I don't fall behind as much in staying on time for my next patient. Occasionally it still happens, somebody dumps a load on you, but in general it's been, within 10 minutes of when the patient arrives and is ready to see me, I'm in the room working with them. And that also has improved the overall efficiency.
So I love that. That's brilliant. He's innovated in the middle of a pandemic, solving a problem both for patients, being able to schedule on their own through his web portal. It's a 30-minute appointment, now down to 25. And if you view the 20-minute long form again on our YouTube channel, ACMS Idaho, you can get more explanation. But those are the kind of things that we were talking about this morning, where it's like, why can't we just share with each other the things that we're doing that are innovative? Those are the kind of things that, as we come up with solutions, would be really cool for you to share. You can see here some of the observational benefits Dr. Fouts and Dr. Armillo have had from that. I don't need to read that, but once again, doing your own thing, being able to create your own solution is a fantastic way to solve some of those and lean into it, feeling like you have that locus of control. Now, if you're interested in some of the organization-directed workplace interventions and the evidence behind those, Dr. Paul Deschamps and Christine Sinski, Dr. Christine Sinski did that with Mayo Clinic, again, 2019. They came up with these 4 domains: teamwork, time, transitions, and technology. They did 50 studies that met their inclusion criteria. The 4 unique categories were identified and briefly described there. And they basically said 70% of those interventions reported success on burnout, job satisfaction, or stress. The largest benefits: interventions that improve process, promoting team-based care, use of scribes, medical assistants, complete documentation of EHR and tasks. Time interventions had mixed effects and actually worsened burnout when they looked at implementing EHR interventions. However, EHR improvements had positive effects. So if you're looking at what are the organizational, where's the evidence behind organizational-based directed workplace interventions, there's some studies there that you can take a look at, a nice study to consult. Now we go to the interpersonal and individual commitments. And these are the anticipate and respond to the inherent emotional challenges of physician work. And multiple people over the past couple of days have been mentioning this inherent emotional challenges of physician work, especially Dr. Serio's talk yesterday. Prioritizing mental health care, practicing and promoting self-care. Now I'm going to stop right here and say, before we talk about individual commitments, I want to make sure you understand. A lot of people say, don't push burnout on me. This is not my problem to solve. This is a workplace issue. You are supposed to solve this, right? So let me preface what I'm going to say here with this. We get to this idea that it's always the person who's making the bricks who has to solve their own problems, right? And Pharaoh, of course, has a triple aim and says he doesn't see what the problems are. Maybe you should try mindfulness or resilience, right? And of course, Moses is like, what a brick, right? So if we're going to talk about physician resilience, self-care, and work-life balance, we have to talk less about what the physician can do for themselves and more about the support that we can give them so that they can do that for themselves. And so once again, social determinants of health was brought up. And a few years ago, I had this idea, what about the determinants of physician well-being? And then I checked this with Colin West, and he emailed me back and said, yeah, we don't know what number exactly it is, but we pretty much agree. 80% of our interventions need to be organizational interventions and 20% individual. But back in 2015, when the big burnout survey that he put out through Mayo proceedings, everybody started talking about resilience, right? Oh, resilience. Yes, you're resilient. You made it through medical school and residency. I believe that you're resilient. We need to think about the culture, the workplace factors, the industry, and how those things drive not well-being, physician distress. So let's talk about anticipating, responding to inherent emotional challenges of physician work. We know there are certain challenges, grief and loss, pain and distress. How do we put coping strategies into training? How do we do continuing education? Those types of things. Once again, we've got a really cool solution for this. It's just an example. It's a narrow example, but I think it's something that could be adapted in different situations. So in the pediatric trauma unit at St. Luke's, I was talking to Dr. Kendra Bowman, and she described this trigger that they built in EPIC, their EHR. And basically they have 5 acute triggers, 5 acute events that trigger an EPIC alert for a peer-to-peer support match. And when one of these things happens, you know, a dog mauling or a code, running a code, or withdrawing life support from a child, one of those 5 things, then the medical staff office gets a ping from EPIC, which causes them to initiate a peer-to-peer match. Now, I know that not all of you are familiar with the peer-to-peer program that St. Luke's and St. Al's has set up here. It's based on Joe Shapiro's work at Brigham Children's Hospital on the East Coast. And they brought her out here together and had her train them on how to set up a peer-to-peer program. And basically the peer-to-peer program is to allow an immediate peer just to help bear a burden that you have. It's not long-term counseling or coaching. It's simply to have somebody next to you if you've gone through a challenging thing, whether it's something like this or another thing like a malpractice suit that's coming up, just somebody that you can talk to, not necessarily about the specifics, but just about your feelings. And they can help point to other resources. And so she says it's like a fire suppression system. It goes off automatically. And I love that idea. And here's the quote that she said, and I just was so thrilled when she said this. She said, it's very much in pilot stage. It's very targeted intervention, but the medical culture has shifted since we started a plan and implemented this program. And I like, whoa, stop the press. The medical culture has shifted because they worked on the solution, right? Now, it's not just about the system doing the trigger, it's about physicians in the department reaching proactively outside of the peer-to-peer process when they know someone's had a tough week. Now we're becoming normal human beings. It's okay to ask for help. I mean, that's where the money is, right? How do we work on things together to move it towards positive change? And once again, I'll go back to Shanafeld's article, Healing the Professional Culture of Medicine. And he shares this thing called the status quo and positive change, tipping the scales in favor of change. And so here's culture at rest, okay? And he says, culture changes when there's a stimulus that upsets the equilibrium. And it could be that the leaders and members of the culture believe something bad's gonna happen if they don't change. Turnover, productivity issues, physician suicide, whatever. And this precipitates survival anxiety, okay? And you think easy peasy, the ball's gonna roll down the hill to a positive change. It's just gonna happen, right? Well, no, because almost simultaneously, survival anxiety comes an opposing force, learning anxiety, and it manifests as resistance to change. And we may not be able to make the changes needed to solve the problem. This is too difficult, it's too costly, it's disruptive. Can we change? What will I lose, right? And what this often manifests as, he says, is minimizing the problem, ignoring the evidence, or total denial. And we have seen all of those happen from healthcare administration, as well as other physicians who say, la, 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 just need to tough up and pull your big boy pants on, da, 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 da. No, we can't keep saying things like that. And what he says, and he explains this, he says, if we decrease learning anxiety, then culture is going to roll in the direction that we want it to, because survival anxiety is going to keep pushing. How do you do that? You create psychological safety to reduce learning anxiety. Involvement in change implementation, asking people what they think needs to change, positive role models, education, opportunities to practice and pilot things, right? Celebrating small wins, supportive structures, process reward control, bidirectional communication. If you want to read more about this, there's about 20 pages of explanation in this in Edgar Schein's book called The Corporate Culture Survival Guide. That's where Shanafeld, I looked at the footnotes and then I went and found the book. It's like, yeah, there's 20 pages of explanation there. So if you want to go look at that, that's a great resource. Edgar Schein's Corporate Culture Survival Guide. Now, once again, if this all feels overwhelming, let's relax and breathe together. Steve, what's in your locus of control right now? All right, and we can go many different directions with this, right? First, we could say, well, it is what it is. Nothing's going to change. It's just things are going to stay the same. It is what it is. It is what it is. You know, it's more of a positive. It is what it is. You do nothing and you accept it. So that is one response, right? Do nothing fatalistic or accepting. But locus of control concept is that, well, we could go inward negative and sulk. We could go outward negative and whine. You could go inward and positive, change yourself. You can go outward and positive and change the circumstance, right? That's the concept, the locus of control concept. And one tool that I think is really useful, and I think Dr. Serio mentioned this again, she just barely brushed upon it, post-traumatic growth. And last year I read a book on post-traumatic growth. It was a little too deep for me. It was all science, and I'm a comm major, you know. So I love these colors, which is why I wanted to show you this, because that complextraumahealing.wordpress.com site has some really cool graphs. But Tedeschi and Calhoun describe post-traumatic growth in 5 domains as positive psychological change experienced as a result of adversity and other challenges in order to rise to a higher level of functioning. This is James Stockdale. This is him saying, I'm looking through the other side and I'm deciding to make a change now with my attitude. So that website is a cool resource. Here's the 5 domains: personal strength, close relationships, a greater appreciation for life, spiritual development, and new possibilities. And this is, again, based on the research of Tedeschi and Calhoun, who described post-traumatic growth and defined it. And I think all of these areas really could be applied to corporations and institutions and medical practices and medical schools and individuals and all that. It just depends on if we're going to have foresight, right? And really, the way that they describe post-traumatic growth is it's something that you don't try to do. It's something that you reflect on and it happens. And somewhere in there, somebody said, well, what happens if you actually try to do that? And they said, well, that's resilience. Resilience is actually doing it in the real time and making change in the real time so that it's not something that affects you negatively, but you're responding to it in a proactive and positive way. Now, I've been around doctors for a while, and I know this is how you think. Once again, oh, I'm bleeding. I guess I didn't realize that, right? Starting with yourself is so important, especially as this initial crisis slows down. Check your own wounds, check your injuries out. And I really believe that here's where I would lay down the gauntlet for you all. By the end of 2021 and every year beyond, think about having a mental health annual checkup. I mean, I listen to my doctor and do my annual mental checkup every year, my annual health checkup every year. And not only that, I turned 50 last year. Guess what I got to go do for the first time? Woohoo! I have a beautiful bowel, according to my person who examined me. And here's what I want to say is, if I'm willing to do what is slightly uncomfortable under anesthesia, right? Are you willing to go and just get one appointment with a counselor and say, am I bleeding anywhere that I wasn't aware of? And here's the power of this is, if you do this, eventually you're going to have an opportunity at some point in your career where you're supervising a student, maybe a PA, maybe another physician, and you're going to want to encourage them to go get some counseling or to go get some help. And if you can say, you know what I do every year? I have a preventative mental health checkup every single year just to do me a once over. That's a powerful statement as a supervisor. And I want to challenge all of you that by the end of this year that you'll have done that just to check yourself over what's happened the past 15 months. Now, you might say, I'm not the CEO. I don't have any power. I don't own my own practice, although I know a lot of you do. What do you do? And here's some of the things that I've written down before. Become the local expert and just talk to anybody who will listen. Because once you do that, you're going to get a reputation and it's going to become one of influence, and you're going to be able to speak into things because you're the local expert and you've done the research and you've read a lot of different things and you can cite some things. That's how things happen. When you do that, you're going to also find other people who care, the co-conspirators and inside champions that you can begin to connect with. Now, one of the questions here was, what's one of the resources? Because the suits aren't paying attention to what's going on. Dr. Christensen, you said, my employer mines for every metric known to mankind, but provider burnout isn't one of their overarching concerns, at least not until the exit interview. Too late. Do you have resources the suits can use on a periodic basis to monitor provider well-being, such as burnout surveys? There's a couple answers there. I'll mention those. One of the things that's important is making the business case for change. And you got to talk the language of the C-suite if you want them to listen to you. All right. And what's the language of the C-suite? Depends on the C-suite. For some of them, it's money. So you got to go to the AMA website and pull down the little tool that's there in the steps forward section, AMA steps forward section, that shows the cost of a burnout physician and what that costs. And they use it based on research, Sinsky's research and the other guys that were with her on that and make the business case. Now, maybe money isn't the most important thing. Maybe it is community reputation. Your hospital, your health system, your practice is the one that wants that little nice crystalline globe in the front. Well, guess what? There are programs called Medicus Integra that's with the Coalition for Physician Wellbeing. And if that's what they want, they can do the work to get that little trophy in their case. Or maybe it's about values. Maybe you're a St. Al's or a Catholic organization like that, and it's all about the mission. Well, pull the mission statement out and show them on the grid. Here's the values, here's the artifact, here's the disconnect. You know, now you got to do that respectfully. You got to do that in a way that's in the right context. But those are ways where you can get to those who are making decisions to make change. Always go after low-hanging fruit, but don't just settle for what is easy. And then check your motives. And I say check your motives because I think sometimes we can become maybe a little bit of a pariah as we begin to be the person with the sword confronting the dragon. And we can think that it's all up to us. No, get other people involved with you. One of the things I remember with Deb Roman, she came on our board. She got so involved in physician well-being, and pretty soon she's organizing this thing with Dr. McEachran, and I'm going, hey, how come Ada County Medical Society isn't in the middle of that? How come we're not there? And I'm thinking, whoa. The whole point of this is that every physician is thinking about this. The more physicians thinking about this, I can step back away from this because someone else is catching when I'm laying down. So when you get other people who are working with you on that, don't worry about who gets credit. Just be very satisfied that there are other people who want to lean into this with you. Well, I want to finish with this. And that is, I'm not a doctor and I don't administrate healthcare. All I can do is provide maybe some encouragement, some inspiration, some research, some resources, but it's upon you, the physicians, to build a culture that is going to bring about sustenance for physicians to practice in it. And so I'll finish here with Dallas Willard, philosopher and writer. Physicians must uniformly develop a strategy to reclaim their professional interest for the good of the whole. As in all professions, only those with the requisite knowledge of the field can bring to bear the full spectrum of issues and opportunities the public faces every day. And of course, that's a picture of the IAFP board, and appreciate all those who serve on it. I will stand for questions now, and I'll also just mention that at the end of the slides and the notes, there's just a ton of resources I wasn't able to get through, so you can see the bibliography there. But with that, what questions do we have? Go ahead, Dr. Bailey, I'll let you.
Yeah, you answered the ones that came up in the chat already. It's pretty easy to moderate you. You do most of the things yourself. So there's no other active questions in the chat.
Well, what I would love to hear is Dr. McGrath, you mentioned, I saw your slide, which I was very interested in. I would ask you, what resources are you using when you're monitoring physician burnout and well-being in your organization? Can we ask him to share?
Can you hear me? We actually have been using the Mayo Clinic Physician Wellbeing Index, and that was initially recommended by the physician wellness officer at University of Washington. And she said it's great because it's free and it's not copyrighted. And so we've been using it for a while, and I think it may actually be copyrighted, but it is a validated tool, and it's particularly been shown to be useful to predict two very negative outcomes, which is a physician leaving the practice within the next 2 years and also physician suicide. So it's apparently been validated for that, but the Physician Wellbeing Index, and I think I put the AMA's tool, which is free. I'm quite confident the Mini-Z survey. I think there's been studies to validate that. I actually just don't remember right now, but I think doing anything, is, I mean, you can make up your own survey, but it's best to go with something that's validated. I think particularly if you're going to have conversations about change.
Yeah. Yeah, the mini Z is free. The Wellbeing Index is not free. People can create their own account, but if a corporation wants to be able to use it, it's about $10,000 a year for physicians, another $5,000 for NPs and PAs, another $5,000 for medical students. We looked at it and it was like, holy smokes, who's got the money to do this? I do know that MIEC Insurance, who's been a longtime insurance partner here in Idaho, they actually paid for it and let all of their policyholders and other people use it. And so that's a link that we could post. But again, you can't really get to it from a corporate level if you're using somebody else's version of it. So that's a challenge. The survey I put at the beginning of the 5 questions, there's actually a validated tool, a study on does a 1-question survey. Does it predict burnout? And they basically show that it lines up with the Maslow Burnout Index, which is that 1 5-point question of how are you doing today and with your job, and I'm ready to go, I'm fired up, or versus 5-point scale all the way to I can't take another step and I don't think I can make it anymore. So there's several things out there. Definitely would encourage that. Also, the professional quality of life. I know that Dr. Serio mentioned that. You can find that online. It's also open source as long as you attribute it, and it measures 3 different domains. It measures burnout, satisfaction, job satisfaction, and I think depersonalization, as well as empathy fatigue. Maybe there's a 4th one on there. So it's called the Professional Quality of Life, PQOL, and you can find that there.
Thank you, Stephen. We had one more question come up, but I think we'll have time to answer before we need to do the video and transition. Dr. Cree brought up that there are nurses leaving the hospital where he works because of the low salaries, and then when physicians complain about being understaffed in ICU in the emergency department, they're just told that they are replaceable. And so he's saying it's difficult to know where to start that conversation if it sounds like the executives aren't even interested in having it. Any thoughts on that?
Yeah, it is difficult to know where to start that conversation, especially if you have a C-suite that is really out of touch with the front line, right? And so the question is, how do you begin to speak to what they value? Again, do they value profits? Well, you need to pull out the research that shows this is going to affect us eventually. And every time we have to replace a physician because they don't have the nursing staff to support them, it's going to cost us $500,000. And if it, so I think that that's the key, is somehow you've got to get inside the head of the C-suite. And maybe that's talking to the VPMA or whoever it is, the physician in that suite, and ask them, what's the most important thing that this board, that the CEO cares about? How do we speak his language, and begin to build a strategy around bringing that discussion forward, inviting them out to the floor, letting them see exactly what the practice looks like when you don't have enough nurses on hand to do the job. Sometimes just bringing them into your world can be a very telling thing. It just, again, it depends a lot on personality and the culture of the organization. The mini Z is something that the AMA, I think that it's called the mini Z because it was the mini Maslow, but they couldn't say Maslow. And so it's a modification of the Maslow Burnout Inventory, which is kind of the #1 researched tool for burnout. They made it smaller and more physician focused. So if you go to the American Medical Association website, type in mini Z, you'll find that there and the research around that.
And Dr. Huberly is just echoing that it is ultimately in the long run not cost effective for hospitals to not take care of their current staff, saying it was more expensive for to bring in travelers to replace people that left. We're going to have to end this presentation here. Thank you so much for that, Mr. Reames.